patient diagnosed at right breast cancer at the age of 32 years, and she is now 34 years. She has no comorbidity or no family history of breast cancer or other malignancy. She was premenopausal at diagnosis and mother of 2 children. The patient presented with right breast lump in upper outer quadrant on 4th quarter of 2018. Core biopsy revealed infiltrating duct cell carcinoma grade 2. Clinical staging was T2N1. Patient underwent breast conservation surgery with axillary clearance up to level 2 on 4th quarter of 2018. And the histopathology report showed infiltrating duct cell carcinoma grade 2. Tumor size was 4 into 3 centimeter, and axillary lymph node showed metastatic deposit of duct cell carcinoma in 12 nodes out of 22 nodes, and the margins were free. Her immunohistochemistry report revealed estrogen and progesterone receptor positive, score 8/8, and HER2 receptor negative. So the pathological staging was T2N3. As it came as N3 disease, so staging investigations were done. And that time, the ultrasonography whole abdomen showed multiple SOL in different sizes in both lobes of liver. Larger one is about 2.3 into 2 cm. So the CT scan of whole abdomen was also done, which confirmed the same findings. CT chest and bone scan were normal. Her liver function tests were normal, and CA 15.3 was 25 unit per ml. So she received 8 cycles of chemotherapy with AC and paclitaxel up to the first quarter of 2019. And after the chemotherapy, her whole abdomen ultrasonography showed still multiple SOL in liver, but reduced in number and size. The patient offered the ovarian ablation that time, but the patient wanted some time. So the patient started the tamoxifen. The laparoscopic oophorectomy done after 3 months, that is the 3rd quarter of 2019. So in the first follow-up in the 4th quarter of 2019, the ultrasonography of whole abdomen showed no SOL in the liver. And the mammography of both breasts done that time, that was no abnormality detected. So the patient missed the follow-up in 1st and 2nd quarter of 2020 due to COVID-19 pandemic. So she followed up at 3rd quarter of 2020. Patient was asymptomatic, but whole abdomen ultrasonography showed again the appearance of multiple hepatic SOS. Her liver function was normal, so the patient started palbociclib and letrozole. She tolerated this dual treatment well, and her follow-up ultrasonography in 4th quarter of 2020 showed the hepatic SOL is static in number and size compared to previous one. So this is up to this time. So my first question is, should we have offered hormone therapy as first line of treatment? Because in the guidelines, there are recommendations for hormone therapy in such situation in the metastatic setup in the first line. And we have the evidences also, but still the significant number of patients in our country receive first line chemotherapy as a first line treatment. So I just want to know from Professor Ben Park, then what should be the standard of treatment in such cases?
I don't think there is a singular correct answer to that. I think certainly because of her young age, many of us would have considered chemotherapy depending on really the size of the, and I think, again, depending on the size and what we might term visceral crises, some might actually have advocated for chemotherapy. I think the regimen, which sounds more like a standard adjuvant regimen, may not have been used because that is a fairly difficult regimen sometimes to go through in a non-curative paradigm, which we are talking about here. So had we used chemotherapy, many of us probably would have used 1 or 2 agents. So again, I don't think there's a right or wrong answer. I think many in this country, though, would have, to your point, started with hormone therapy with the CDK4/6 inhibitor. I think the thinking before the advent of CDK4/6 inhibitors was that if someone did have visceral crisis or visceral metastasis, chemotherapy would have been chosen first. But I think with the advent of these new class of drugs, particularly in the first one, palbociclib, the Paloma-1 trial really demonstrated that in first-line therapy, patients, even with visceral disease who received CDK4/6 inhibitors with letrozole actually did better than just letrozole alone. So that has really become our new standard of care. But at the same time, is it the only way? I would argue that is not true. And many of us would have used chemotherapy as well. I do also want to make the point, because I read ahead with the questions, that in both cases today, the age, even despite the lack of family history, we would also recommend genetic testing. And in particular now with the potential therapeutic implications of having a germline BRCA1 or 2 mutation, one can get the new class of drugs, PARP inhibitors, which are also remarkably effective in the first and sometimes second line setting.
Okay. My question, if the ERPR score were 5 or 4, just suppose, that time would you like to offer chemotherapy if it is low scoring?
Yeah, I agree with you on that. So we always debate what is truly meaningful ERPR positivity. And, you know, in this country, even 1% is technically considered hormone receptor positive. And we technically could offer patients those, but I think many of us feel like that's not going to have a high likelihood of response. And so even in our clinical trials, we debate whether we should allow patients that have less than 5% or less than 10% of breast cancer cells staining for either ER or PR. And I agree with you, if there's equivocal nature about the estrogen receptor or progesterone receptor positivity, then many of us would have started with chemotherapy.
So do you think in such setting, such a young patient with de novo metastasis, sometimes it's difficult to convince the patient to take that tablet instead of chemotherapy, because they are tuned with that they need chemotherapy. So sometimes it's very difficult for us to convince the patient for hormone therapy. So what do you do in your clinical practice?
Same is true here, but I think in this country, at least, many patients are relieved when we tell them they don't need chemotherapy. At the same time, I warn them that CDK4/6 inhibitors can have side effects like chemotherapy, and that they are not hormone therapy, that they're really targeted therapies, and can have side effects, particularly on the bone marrow, as you know, that is very, very akin to chemotherapy. And that's why we have to monitor the blood counts. And sometimes we have to adjust doses just like chemotherapy. So it is, again, how we approach the question in terms of how we answer it. My strategy has been in the past that this is not chemotherapy, but it is also not just hormone therapy, and it's kind of in between and offers a more powerful option with less side effects.
So considering our low resource setting, do you think does every patient need CDK4/6 upfront, or we can go for go sequentially? Like these are very de novo metastatic patient. This patient is very sensitive to hormone. So can we go sequentially, like ovarian suppression and tamoxifen and then letrozole and CDK4 like this, or from upfront we should give this CDK4/6 inhibitor?
Again, I think that's going to be situationally dependent, and I don't think anyone here would have said that she absolutely should not have gotten chemotherapy firsthand. I think many people in our country would also have treated her with chemotherapy. Again, I'm less likely thinking that it would have been 3 chemos, because we know that in the metastatic setting that this is not curable. And past studies have demonstrated that multiple chemotherapies versus sequential is not really difference in terms of overall outcome. But at the same time, I don't think there is a singular answer to your question. I think some people might have actually considered upfront CDK4/6 inhibitor therapy and with hormone therapy. And I do think in those circumstances, even visceral disease. But again, I don't know how many liver lesions she had, and in someone so young, I don't think anyone would criticize what was actually done here in terms of the sequence of events. Unfortunately, we are not talking about a curative paradigm, as we know. And so using it as second line or first line, and in fact, in the Paloma-1 trials, they did allow chemotherapy up front and patients to enter. So it's really first-line endocrine therapies, if I recall some of the eligibility correctly. I actually think the other thing to keep in the back of your mind is that she may have, again, if she has a germline BRCA1 or 2 mutation, other therapeutic options in terms of PARP inhibitors. But if that's unavailable to you, platinum drugs probably work through a very similar mechanism. And so in many of the PARP inhibitor trials for germline BRCA1 and 2 mutation carriers with metastatic disease, previous platinum therapy was not allowed because that probably portends that they're not going to be as responsive. And so if PARP inhibitors are not available to you, then that is a potential option of using platinum therapies in the future, should she actually have any BRCA1 or 2 mutations, or even if she doesn't. And then similarly, there are new other agents here. I think you probably have them, everolimus, also known as Afinitor.
We have everolimus.
Yeah, and so that's another option that she would be eligible for in the future. And then finally, many of us are finding that when patients progress on palbociclib, they are not necessarily resistant to all CDK4/6 inhibitors, particularly abemaciclib. And so if you have that particular drug available, I myself have put 3 patients who have progressed on palbo and then put them on abemaciclib, either sequentially or later on in their course of therapies, including one patient who had a complete response. And so there's a paper coming out. There are 3 abstracts at San Antonio suggesting this. And there's a paper coming out also demonstrating that not all patients will be pan-resistant to all CDK4/6 inhibitors.
So you recommend if the patient progress in one CDK4/6 inhibitor, I can switch to another one?
You may be able to. Abemaciclib is the one that we have the most experience.
But in the NCCN guideline, they have written that if the patient progressed in one line of CDK4, there's no rationale of using the other CDK4/6 inhibitor. But this is a very...
So that is conventional thinking, but it was actually never really proven. And so from a scientific standpoint, that may make sense. But from a clinical, real-world, pragmatic viewpoint, many of us have done this. And again, there's literature now to support this. So the thinking on guidelines will likely change. For sure, there are patients who develop pan-resistance. And if you have next-gen sequencing available for tumor testing, that might be a way to look at that. As an example, we know that the tumor suppressor gene RB1 can be mutated, and if that's mutated as a resistance mechanism to palbociclib, it's also likely going to be resistant to all the CDK4/6 inhibitors. But in our experience, that doesn't happen that frequently in terms of RB loss. And so there are patients for sure who are going to be sensitive, and sometimes very much more so than not from one CDK4/6 class to another. In fact, when you think about it, hormone therapy is the same. There have been patients documented who progressed on non-steroidal aromatase inhibitors like letrozole and anastrozole, and yet still can respond to exemestane or tamoxifen. And so there are non-overlapping mechanisms of resistance that we can sometimes use.
So I can change either CDK4 or the hormone partner, the next, if the patient progressed palbo plus AI, letrozole. No?
Yeah, I might actually change both.
Both. Okay. We don't have that much option, really. We only have this palbociclib. Okay. Let's go to the second question. Did PET-CT have any role in the course of treatment? I mean, in our low resource setting, if the conventional imaging can conclude the finding, and I can take the decision based on this, do I really need to do a PET-CT? Dr. Rajesh, sir.
In our context,
you know our context. We can't do very repeatedly PET-CT for follow-up. So
PET-CT availability is a bit of an issue in the Asian continent. If you see, the centers which have PET-CT are very limited, and they are all widely spread apart. I would say, like, if you are able to find that there is a metastatic disease by the conventional methods itself, by using a CT, ultrasound or something, I don't think PET will add anything much more to the thing. So basically we can get away without doing a PET also in this scenario. But for affordable patient where you definitely have the options, definitely it will help you in guiding the further treatment. Basically, because once you have a metastatic disease, you give them systemic treatment and you find that the patient is responding well. Then there is a point that at some point of time you might be tempted to offer the patient some loco-regional treatment either in the form of surgery or RT. And that's the time when I feel that this PET scan would be more beneficial.
Okay. So when you just think for some local treatment, that time PET CT will be beneficial.
Before offering a loco-regional treatment, better to rule out the disease extra. There is a disease outside the breast and the nodal disease is under control.
Okay. So Dr. Ben, do you have any comment regarding this PET CT?
Yeah, in this country, PET CT is optional for staging, and really, this guideline still state our standard of care is a bone scan and a regular CT scan. The bone scan, obviously, to rule out bony mets, and the regular CT scan to look at more visceral and soft tissue potential metastatic disease. And so, again, I don't think you need to do it. I do think it may offer a little bit of benefit in terms of sensitivity, but I feel like in this particular case, we know that she had liver mets, and if she has any other symptoms, I might actually try to get a bone scan if she hasn't had one already, particularly because if she has bony metastasis, we can treat those with other agents.
So how frequently this PET CT change your treatment decision making? Is it very...
Not very often.
Not very often. Okay.
Yeah, as long as they have other staging scans.
Okay, great. So my third question is to Dr. Rajesh. Is there any role of whole breast radiotherapy plus regional nodal irradiation for this patient? This patient was N3 disease, and this is that point of time when all the liver mets were disappeared. So that time, is there any role of whole breast radiotherapy for this patient and the RNI?
Basically, if you see systemic treatment is the standard treatment for metastatic breast cancer. The value of loco-regional treatment for the primary tumor is controversial. Most of the time, it depends upon the response to the systemic treatment. Majority of the time, why we consider loco-regional treatment is we think that by removing the primary tumor, we can reduce the tumor burden. Thereby, we can increase the response to systemic treatment. That is one thing. And second thing, what we can think about is the primary tumor is the source of the new clonal cancer cells or the cancer stem cells. Thereby, if you remove the primary tumor, then we can get the primary tumor under control or the disease under control. There are some reports by saying like primary tumor, if you remove, it can reverse the tumor-induced immunosuppression also. Yeah. But I would restrict the loco-regional treatment only to patients who are having metastasis which is limited to bone only, or if the patient has a very favorable response to the primary systemic treatment, and you have a primary which is resectable. So that is the one which I'll take. But for this patient, if you see, the treatment, what I would have offered earlier would be like to start with systemic treatment and then take up for surgery rather than the other way. For this patient, the patient had first surgery and then you had given systemic treatment. My take would have been that I would have offered systemic treatment upfront and then taken up the patient for a surgery at a later point of time. The reason for this patient, if you see, there won't be much benefit by giving the chest wall RT and the regional nodal RT at the time when there is liver metastasis. Maybe we could have tried this at the point when the disease was under control. That is, a metastatic disease was not there in the liver. That is one point of time. But we could not have expected an overall survival benefit because it's not found. There was a randomized trial done in Tata, which they published in Lancet by Dr. Badwe, where they randomized patients with loco-regional treatment versus patients with no loco-regional treatment. Okay. They did not find any overall survival benefit. But there was one trial from Turkey. So Turkish group, they were able to show a survival benefit. But because of this, there was one recent publication from London by Gira's group. So they had done a meta-analysis of near about 90 trials where they found that there is no overall survival benefit, but loco-regional control is better, but HRQOL, there is a quality of life is worse in patients who had loco-regional treatment than compared with only systemic treatment. So I would restrict my local regional treatment to only patients who have very, very good response to systemic treatment, bone only disease where we can expect a longer survival, ER positive patients, plus younger age group patients, only those sort of patients I would be restricting.
But not for this type of liver
Not
mets.
for this type of patient who has visceral mets and patient who's not very regular in follow-up.
Okay, thank you. So my last question is, what is the role of biomarker testing and when is the right time to do the test? I think Dr. Ben have already mentioned some of this, but I would like to hear more details from him regarding this. So should we do this biomarker testing just upfront from the diagnosis of metastasis or the later when the hormone resistance developed?
So by biomarking tested, do you mean like sequencing of the tumor and molecular testing?
Yeah, the PIK3CA mutation or BRCA1 mutation all.
Yeah, I tend to do it up front for the germline testing. So those are the heritable mutations like BRCA1, BRCA2, if they qualify, and certainly her young age makes her eligible, at least in this country. In terms of testing the tumor, if that's available to you, we tend to do this right now in this country for breast cancer only in metastatic disease. And so I probably would not have done this if this was an early stage breast cancer patient, because it really would not affect our management decisions. Yeah. But if this is a patient now with metastatic disease and she has a PIK3CA mutation, we now have a drug, as you know, alpelisib, so that could also be a future option. And we may find other off-label use or clinical trials targets that we can therefore have this patient be considered as a participant.
Okay, so I think my time limitation has already reached the point, and now I would like to request our panelist, Dr. Salim Reza sir, to make his valuable comment regarding this.
Thanks, Dr. Shahida Alam, for your case presentation. This is definitely an interesting case, and actually it's common in our Bangladesh, as the maximum patients are diagnosed as metastatic settings. So treatment option is same, already you have mentioned. I am agree with all the answers of these to our international panel members. So thank you again.
Okay, so it's over to Professor Salma ma'am. So I would like to hear something from you.
Thank you. Dr. Shahida, that was a nice session and nice moderation. Thank you. Okay, so I had a little question that usually we surgeons, when the patient comes, we do the staging investigation before any surgical management or any tumor board decision. Whether in this case, the staging investigation, that is the ultrasonography of the liver, abdomen, was done after the surgery. It's not clear from the presentation.
Yes.
And the question, actually it's my query, or I want to know from the panelists that if the staging investigation was done before the surgery and it has been found that there is multiple mets in the liver, whether the surgery, whether the management plan would have changed before doing the breast conservation, or you would have started with the neoadjuvant planning.
So, ma'am, if you looked at the case history, the patient was presented at the T2N1 disease that clinically that was a stage 2B, and she was asymptomatic. According to the guidelines, our guidelines, that is NCCN guidelines, ISMO and NICE guidelines, there is no recommendation of doing any staging investigation in asymptomatic patient with early stage breast cancer, that is stage 1 and 2. Only the symptomatic patient, we can go for the CT scan with contrast, chest and abdomen with contrast and bone scan. So in this case, the patient was in early stage, asymptomatic. That's why no staging investigation were done.
Yeah, I have seen the NCCN guideline that the guideline says that the ultrasonography as needed. But usually in our practice, that is the guideline. Shahida, you also know that we have to manage our patients in our social context. in our patients, we usually go for at least an ultrasonography of the abdomen.
But our patient is not biologically different from others. Our contrast is not. So we follow the guideline. At least there's no recommendation for asymptomatic patient to do any staging.
Yes, I understand.
So I want to know the comment of Dr. Ben Park regarding this.
Yes. My query was that if it was diagnosed before surgery, whether the plan of management would have changed or not.
Yeah.
That is my query.
Yeah, definitely it would have changed that time. So Dr. Ben, do you routinely do staging investigation in early stage breast cancer patient, asymptomatic breast cancer patient?
No, we follow the guidelines because here, we're one of the few cancer disease groups where we have evidence that less than 1% of the time without symptoms in earliest stage disease, you will not find anything. So clinically, if she's stage 1 or stage 2, we would not have done further staging. But to the point, yes, if we had found metastasis, we would have had a very different approach and probably not have done surgery, but tried systemic therapy, as Dr. Balakrishnan said earlier, for local regional control. We tend to just do it for good prognosis patients, bone-only disease, and first hope to see a shrinkage because there is limited data to support doing it up front.
So Dr. Rajesh, what would you do? You do the staging investigation for early stage breast cancer asymptomatic patients?
If there is a node palpable, definitely I would have done.
Still in one node.
Yeah. Basically, even N0, we should try to do an ultrasound, breast and axilla, definitely say it's negative, then proceed with surgery. Clinically, node negative doesn't mean that there is no node in the thing, but something we can find nodes in the axilla on ultrasound, which might be radiologically malignant.
Yes. So if it is radiologically malignant.
Any comments, sir?
Regarding such situation, what we should do in our country context.
Salma has made one issue, especially whether we should go for the ultrasound of the, especially to detect liver mass or not before going for any surgical procedures. Because in our country, everybody has to pay from his own pockets. And in European American centers, there is a guideline, and they have to follow the guideline because the insurance will pay for all the investigation and others. So in our country, what we do actually, before going for any types of treatments, we do ultrasounds of the patient, the abdomen to see the liver mass or not. Even we do the imaging also, in every case. Because when we are treating the patients with a lot of expensive therapy, always there is a questions, and the question comes to the patient also, guardians. When the patient comes with mass, liver or other things, especially the lungs, they arise the question, especially you have done a lot of expensive therapies, but you didn't did that in investigations before doing any type of treatments, starting the treatments. That's good. And one thing Lima is telling, especially regarding the PET scan, because thing is that always it thinks to me also you were putting in a very expensive therapy like palbociclib and other things, very expensive on a country, but a PET scan is not that much expensive in this case, because PET scan, even what Rajesh has told, 15% benefit you can achieve than the modern imaging. You can, but not in all cases, but even you can find a lot of new lesions that cannot be actually finds in the CT scan or other modalities than the PET scan. So that's definitely.
So thank you so much, everyone, every panelist, for your wonderful discussion. We have learned so many things.